So I've been asked to argue for using single-agent Brentuximab in the second-line setting for Hodgkin lymphoma. And I'm going to start with a case. This is a 27-year-old woman who was initially diagnosed with stage 4B classical Hodgkin lymphoma with involvement of her liver and bones. She had received 6 cycles of ABVD and had a complete response, but then unfortunately 1 year later developed B symptoms and pancytopenia, and her PET scan, as you can see on the slide, showed diffuse bone involvement. She had a bone marrow biopsy that confirmed relapsed classical Hodgkin lymphoma, and her counts were quite low at the time. She had a neutrophil count of 0.8, a platelet count of 61,000. So she was somebody that would have been difficult to treat with combination chemotherapy. So what is our general approach for a patient like this? In general, our approach is for patients who have failed their frontline therapy, is to give some type of second-line chemotherapy, followed by consolidation with an autologous stem cell transplant. And we can cure about 50% of patients with this approach. So with regard to what second-line therapy do we use, the regimens that we have available are really pretty similar. If you compare ICE, DHAP, gemcitabine-based therapies, the complete response, either if you measure by CAT scan or if you measure by PET, are quite similar. So there's not one standard approach. Multiple groups have looked at prognostic factors in the pre-transplant setting, and one of the most important prognostic factors that have been found is whether or not a patient can achieve normalization of their PET scan. And this is just a summary of multiple studies looking at this. As you can see, in the patients who have a negative PET scan would be expected to have somewhere between a 70 to 85% chance of being cured, while those with a positive PET scan going into transplant would have a much less favorable outcome. And this is just an analysis from our institution looking at patients who were treated over a 9-year period going to transplant for relapsed or refractory Hodgkin lymphoma. And as you can see, the patients who had a negative gallium scan or PET scan had close to about an 80% chance of being cured, while only about a third of the patients who had a positive gallium or PET scan were cured with this approach. So based upon this, in 2004, a study was designed at Sloan Kettering where the goal of the salvage therapy was to achieve normalization of the PET scan. And patients who enrolled on the study first received ICE-based chemotherapy, and then they were analyzed but with a PET scan. And those who had a negative PET scan went on to transplant. Those who had a positive PET scan received additional non-cross-resistant chemotherapy with GVD, followed by consideration for a transplant. And these were the results from that study. There were about 100 patients on that study, and about 60 of those patients achieved normalization of their PET scan with ICE-based therapy alone. And you can see them on the blue curve on this curve, and as you can see, their outcomes were quite good. Of the roughly 40 patients who had a persistently positive PET scan after ICE-based therapy, about half of those then normalized their PET scan with GVD-based therapy, and those patients are seen on the green line. So as you can see, the outcomes for the patients who had a normal PET scan going into transplant was quite good, and actually the results were interchangeable whether they required just ICE therapy or if they required ICE followed by GVD. So our conclusions from the study were that, first, the goal of salvage therapy should be to normalize the PET scan going into transplant, and also it doesn't really matter how we get there. So around the time that study was closing, the data regarding Brentuximab vedotin became available, and it was clearly seen that Brentuximab was a very active drug in the post-transplant setting. And so we were interested in evaluating it in the pre-transplant setting. And we were particularly interested in a different schedule for Brentuximab. The approved dosing for Brentuximab is 1.8 milligrams per kilogram given on an every 3-week basis. And at that time, there was a phase 1 study looking at weekly Brentuximab, where it was given 1.2 milligrams per kilogram, 3 weeks on and 1 week off. And we felt that this was a desirable regimen in the pre-transplant setting because it allowed us to give an increased dose intensity of the treatment and potentially have CCRs, complete responses earlier on, and get patients to transplant. And in fact, on this phase 1 study, there were about 41 patients. The complete response rate was similar as was seen in the pivotal study using the standard dosing, but the majority of those complete responses were seen quite early at about 8 weeks. So the design of our study was that patients received single-agent Brentuximab on this weekly basis for 2 cycles, and then were evaluated with a PET scan. And those who had normalization of their PET scan went right on to transplant. Those with persistent abnormalities on their PET scan were given additional chemotherapy with augmented ICE for 2 cycles, and then reevaluated with a PET scan. And again, those who had normalization of their PET scan went on to transplant, and those with persistent abnormalities could be treated according to the doctor taking care of them. We had very strict criteria as far as what we defined as a negative PET scan on this study. Patients who required to have a Deauville score of 1 or 2 in order to be considered negative. And we did this because we were a little worried about eliminating ICE-based therapy for these patients, since that's what we had been doing we had been using that for many years. And so we wanted to make sure that we weren't under-treating patients. So on this study, we enrolled 45 patients, and it was overall a fairly high-risk population. About half of the patients had primary refractory disease. Another third of the patients had relapsed within 1 year of their initial treatment. Almost half of the patients had extranodal extension of their disease, and about a quarter of the patients had B symptoms going into upon enrollment onto the study. And this is what we found on the study. Of the 45 patients who were enrolled, 12 of the patients achieved normalization of their PET scan with just Brentuximab and went on to transplant. Of the rest of the 33 patients, there was 1 patient who came off study. And then the majority of those patients who received augmented ICE achieved normalization of their PET scan and went on to transplant. It turns out that the 10 patients who had persistent abnormalities on their PET scan following augmented ICE, they also ended up being referred to transplant. So 44 of the 45 patients enrolled on this study went on to transplant. And this is just a summary of the Deauville scores. As I mentioned, the Deauville score of 1 or 2 was defined as a negative PET scan. And so and within the patients who were defined as a positive PET scan or having had a positive PET scan, there were quite a few patients who had a Deauville score of 3. There were 8 of those patients. And so actually, many of these patients actually had quite good responses, even though we were defining them as a positive PET scan. And then of those patients, the majority of those patients then normalized their PET scan and achieved a Deauville score of 1 or 2. So these were the results from that study. And so as you can see from the blue curve, the patients who had normalization of their PET scan following Brentuximab vedotin alone had a very good outcome with close to over an 80% long-term event-free survival. This is after following patients for at least 9 months after transplant. Patients who required both Brentuximab followed by augmented ICE in order to achieve normalization of their PET scan also had a very similar outcome, and you can see them on the green line. And then, as expected, the patients who had persistent abnormalities after Brentuximab and augmented ICE did not do as well. So there was a similar data that led by Rob Chen from the City of Hope, who you'll be hearing from shortly, where the standard dose of Brentuximab was used as first salvage for patients who had failed their frontline therapy. On this study, patients received 4 cycles of Brentuximab, and then if they had an adequate response, they went on to transplant. If they did not have an adequate response, they received additional salvage chemotherapy and then went on to transplant. On that study, they saw similar response rates as we saw with single-agent Brentuximab, with about a third of the patients achieving a complete response to Brentuximab. Now, what about adding additional chemotherapy to Brentuximab? There are 3 main studies that are looking at the combination of standard chemotherapy drugs in addition to Brentuximab. The combination of ICE plus Brentuximab and DHAP plus Brentuximab, those studies have not yet been reported. However, at this past ASH, we saw some initial results from the Bendamustine plus Brentuximab study. So Anne LaCase presented this data at this past ASH, and it was evaluating Brentuximab plus Bendamustine as first salvage for patients with Hodgkin lymphoma. And this is the overall schema for this study. Patients could receive 2 to 6 cycles of Brentuximab plus Bendamustine. The majority of the patients actually received 2 cycles, or the median number of cycles given was 2 cycles. And patients were evaluated, and they could go on to transplant if they were eligible. And then after transplant, they could receive additional Brentuximab as maintenance. There were 54 patients enrolled onto the study. And the complete response rate, so not just the overall response rate, but the complete response rate to this combination looked quite good. 83% of the patients had a complete response to the combination of Bendamustine plus Brentuximab. So that was quite impressive. Now, there are some caveats to these findings. One of the caveats is that for some reason there was a high rate of infusion-related reactions with this combination. And that's not something that I would have expected, having given a lot of single-agent Bendamustine as well as single-agent Brentuximab. I don't tend to see significant number of infusion-related reactions with either one of the drugs alone. But up to about 50% of the patients had any type of infusion-related reaction with the combination. And before they started requiring that patients got pre-medication to prevent the risk for infusion-related reaction, about a quarter of the patients had a grade 3 or worse infusion-related reaction. This improved dramatically to only about 10% of the patients once they required pre-medications. The other caveat or the other finding from this study is that at this point, with very short follow-up, they're already seeing 4 progressions following transplant. Now, this is supposed to be the best case scenario where patients are going to transplant in a complete response, and so it's surprising that with such short follow-up, we're seeing progressions already. And I think at this point, we need more follow-up to make sure that these responses that the complete responses that they were seeing with the combination are going to hold out. And so this kind of raises the question in my mind, as I always had thought that everyone who is PET negative is all equal, and it doesn't matter what type of treatment it's required in order to become PET negative. But this may change. Now I'm questioning this when I see the data with Brentuximab plus Bendamustine. And as I mentioned, our original data where patients got ICE plus GVD, the event-free survival curves, they plateau at about 80%. And so patients who have a negative PET scan, have a very good chance of being cured. And likewise, with our data with single-agent Brentuximab followed by augmented ICE, the event-free survival curves plateau quite high. And at this point in time, we're not seeing that with these curves, although we really do need more follow-up. So what did I do for our patient, who I presented in the beginning? So as I mentioned, about a year after completing her treatment with ABVD, she had pancytopenia, significant B symptoms. At that point, we did have a study available, so we enrolled her on study, and she received 2 cycles of single-agent Brentuximab given on a weekly cycle, or weekly schedule. And this is her PET scan seen after Brentuximab, where she had improvement in all of her bony areas, although she still had some mild abnormalities of FDG-avid abdominal lymphadenopathy, and so she was actually considered to have a Deauville 4 response. So she went on to receive 2 cycles of augmented ICE, to which she achieved a Deauville 2 response, and she went on to an autologous stem cell transplant, and she's now remains in remission 3 years after transplant. So in summary, my choice of treatment for of someone who has failed their frontline therapy is single-agent Brentuximab, and that's because of 2 reasons. One is because I know that I can use the PET scan to determine who might need additional therapy if the Brentuximab is not sufficient, and also because I also feel that it does not matter how many steps it takes, or at the very least we can take 2 steps in order to become PET negative prior to transplant. Now, I know that there is significant room for improvement, and it would be nice to see a higher CR rate with single-agent Brentuximab. But at this point in time, I don't think we have enough data to say that the addition of Bendamustine is the answer, and I'm not sure that the addition of other multi-agent chemotherapy drugs will be the answer either. As mentioned earlier today, there are a number of combination studies looking at Brentuximab with other novel agents, including anti-PD-1 therapy. And so it would be nice to see high CR rates with regimens such as those, as well as durable remissions. And maybe in that case, we'd be able to replace single-agent Brentuximab and not need to talk about these traditional combination chemotherapy drugs. Thanks so much for your attention.